vessels in the body. And for men that have smoked, it's known that there's an increased risk of that particular artery becoming abnormally enlarged, and in some cases it can burst. So it's recommended that folks who have smoked have that screening with an ultrasound. It's only a one-time test, so that will for those folks that fall into that. That's definitely a discussion for you and your doctor. Next slide, please. So in this particular section, we're going to discuss some of the, we're going to be discussing cancers and some of the most prevalent cancers that are relevant to men. Next slide. So we'll start with testicular cancer. And so studies show that about half of these cases occur in men who are relatively young, between the ages of 20 and 35. However, it is known that this cancer can occur anywhere from an infant all the way to elderly men. And it's been found that it's more common in Caucasian men, but the rate of testicular cancer has actually increased over time for reasons that aren't completely clear. But it is important to remain aware of this condition. The good news is that testicular cancer is one of the most curable cancers out there. It has in excess of 95% cure rate. So on an annual basis in the United States, about 10,000 men are diagnosed every year with testicular cancer, but there are fewer than 500 deaths per year. Conducting self-examinations may be beneficial, but discuss that with your doctor for additional questions you may have. Next slide, please. So moving on to prostate cancer. Prostate cancer is by far and away the most common cancer in men after skin cancer. And we'll touch on skin cancer in a moment. More than 2 million men in the United States are considered survivors of prostate cancer, but about 1 in 9 men will be diagnosed during their lifetime. So those numbers may sound high, but prostate cancer is a very treatable cancer. So it's important to be proactive in having these conversations with your doctor around whether or not screening may be right for you. So the American Cancer Society recommends that men make an informed decision by having a conversation with their doctor, taking each individual's unique situation and health conditions into account when having that conversation. So even though we're talking about prostate cancer screening, your doctor may not recommend that you have a prostate cancer screen, even if you are in a certain age group. However, generally speaking, men at age 50, being of average risk, meaning you don't have a strong family history, you should begin to have conversations with your doctor about whether or not screening is right for you. Additionally, men who are 45 should begin to inquire about potentially having screening tests done if you have an immediate family member, and at age 40 if you have multiple family members who've been afflicted with prostate cancer. So again, prostate cancer is very readily treatable, and screening can be the appropriate next best step for you, but not necessarily. So again, I'm going to reiterate time and time again that having those conversations with your doctor is most important. Next slide. So our next topic is colorectal cancer. So excluding skin cancers, colorectal cancer is the third most commonly diagnosed cancer in both men and women in the US. The overall lifetime risk of developing skin cancer or colorectal cancer is about 1 in 23. The risk is slightly lower in women than men. So colorectal cancer is the third leading cause of cancer-related death in the United States for both men and women. It's the second leading cause of death overall when both sexes are combined. So overall, around 53,000 deaths from colorectal cancer were reported in 2020 alone. So additionally, more cases of colorectal cancer are being found in earlier ages, and as a result, the U.S. Preventive Service Task Force which oversees all preventive testing in the country, has recommended a decrease in the age of first testing from age 50 to age 45. And this is for people of average risk, meaning you don't have a strong family history, you don't have a personal history of polyps, and you don't have a genetic condition which may predispose you to colorectal cancer. So again, some of those high-risk conditions do include family history and a genetic condition, but also can include a condition called inflammatory bowel disease, which we're not going to get into, but it's something that is not very common, but is likely that your doctor will have that conversation with you if you are diagnosed with that condition. There are other lifestyle-related risk factors, although they don't necessarily have a cause effect, but you can see on the slide that there are a number of other risk factors that can predispose you to colorectal cancer. The screening of choice, there are a couple of ways that it can be screened. The gold standard is colonoscopy, but there are other testing methods that can be performed these days as well. So just to make sure you're having those conversations as well. Next slide, please. Okay, so I'm not going to say a whole lot about skin cancer, but skin cancer can be lumped into two broad buckets. One is non-melanoma skin cancer, and the other is melanoma skin cancers. So non-melanoma skin cancers are flesh-colored skin cancers, whereas melanoma skin cancers are the pigmented cancers. So skin cancer, including both melanoma and non-melanoma, is by far and away the most common cancer diagnosed in the United States. But because of the extremely high cure rate of non-melanoma skin cancer, the overall death rate doesn't even make the top 10 killers of men or women in the country. The big takeaway for you here is that the single highest risk factor for developing skin cancer is exposure to UV rays. So minimizing your exposure through either avoiding sun at the most intense times of the day between 10 and 4 p.m. generally speaking, and using protective clothing or high SPF 30 or greater sunscreen. Those are the best ways to move forward on that. Next slide. So at this point, we're going to transition and talk about heart health for a moment. We're just going to briefly touch on 3 risk factors and 3 types of testing that you need to keep your eyes on, but also discuss some of the signs and symptoms of both heart attack and stroke. Next slide. So as we alluded to earlier, the 3 numbers that you want to be most keenly aware of include blood pressure, cholesterol levels, and waist size. So knowing your heart health numbers can be life-saving, and these 3 numbers are critical. So blood pressure is broken down into 2 numbers, and you might have seen this. The top number is referred to as the systolic blood pressure, which is the blood pressure when your heart is squeezing. And then there's the diastolic blood pressure, which is the blood pressure, that's the bottom number, and that's when the heart is relaxing. And it's important to know both of these numbers to be in a healthy range, and that while we're not going to get into the details of the blood pressure, it's important that you discuss with your doctor what your numbers are and what they represent. They may represent a reading in which you may be at risk for high blood pressure, or they may be representative of high blood pressure, which needs to be treated. Both the high blood pressure is clearly has a strong association with heart disease. as does the next one, cholesterol. So high cholesterol is one of the major risk factors. And in fact, the higher your blood cholesterol level, the greater your risk of developing heart disease and a heart attack, as well as stroke. And finally, we're going to briefly discuss waist size, which it even in comparison to the BMI number that we talked about before, waist size has a stronger correlation with heart disease. So studies have shown that women with a waist size over 35 inches and men with a waist size over 40 inches have been shown to have an increased risk of cardiovascular disease, diabetes, metabolic problems, as well as high blood pressure and abnormal cholesterol. Next slide. So heart attack warning signs. So we want to, in prefacing your risk and sharing those numbers that we talked about earlier, that gives you some clue as to where you're at and what you need to be aware of in your overall risk for developing a heart attack, which is by far and away heart disease and stroke are the two biggest killers of men in this country. So not all heart attacks begin with sudden crushing chest pain as shown on TV or in the movies. In fact, about a third of patients who have had a heart attack have actually had no chest pain. So the symptoms can vary from person to person, but some of the symptoms you need to pay attention to include chest pain or discomfort, upper body discomfort, including shoulder and classically left shoulder pain is thought to be related. Shortness of breath may be your only symptom, particularly folks with diabetes. They are less likely to experience pain when having a heart attack. Other common symptoms include breaking out in a cold sweat, feeling unusually tired, nausea, vomiting, and lightheadedness. So if you're feeling out of the ordinary and some of these symptoms come on suddenly, don't wait. And do not feel embarrassed to call for help. If there's any question at all, call 911. Next slide. So just kind of bringing it to a close here for this section. Stroke, similar to a heart attack, you can think of a stroke similarly because both are caused by low blood flow. So heart attack is caused by low blood flow to the heart arteries, and similarly, stroke is caused by low blood flow to the brain. So a stroke, like a heart attack, is also a medical emergency. It's important to recognize these symptoms such that emergency services can be activated immediately by calling 911. Time is of the essence, and it's ideal from the time of symptoms to the time of treatment to be 60 minutes or under. And some of those symptoms can include sudden numbness or weakness of the face, arm, leg, confusion, trouble speaking or trouble understanding speech, sudden trouble seeing in one or both eyes, trouble walking, dizziness or loss of coordination, and a sudden severe headache without a known cause. Okay. Next slide. Do we want to? Yeah, thank you for muting that. So this slide just summarizes some of the daily steps to health, and I would just encourage y'all to again have these discussions with your doctor, stay updated with immunizations, and we haven't touched on immunizations, but there are a whole host of potential immunizations depending on your stage and age. So eating right, avoiding excess alcohol, obviously illegal drugs, remaining physically active, managing your stress, and keeping that relationship with your doctor established. With that, I will go ahead and pass the baton on to Dr. Langmaid to talk about sexual health.
Thank you, Dr. Lesko. My name is Dr. William Langmaid. I'm here at Blue Cross Blue Shield of Texas. Thanks, y'all, for allowing me to join in your talk today. I'm going to be talking to y'all about STDs and prevention of STDs and treatment. We can go to the next slide. Okay, so men's sexual health is a state of well-being. It allows a man to fully participate in and enjoy sexual activity, and it includes a full range of physical, emotional, interpersonal, and social factors. Optimal male sexual health involves sexual desire, also known as libido, and erectile function, the ability to sustain an erection. Next slide, please. There's quite a few causes of poor sexual health. There are physical and medical concerns, such as heart disease, high blood pressure, high cholesterol, diabetes, low testosterone, and in the use of some prescription medications. There are psychological factors like stress, exhaustion, fatigue, anxiety or depression, and maybe a history of sexual trauma. There are interpersonal issues like relationship problems or concerns, trust and intimacy issues, increased age, and poor communication. And then social factors like alcohol use, smoking, recreational drug use, or too much or too little physical activity. We can go to the next slide, please. So the Centers for Disease Control recognize two terms. Many people are more familiar with STD, but there are two terms. One is sexually transmitted infection, and that refers to the cause of the infection through sexual contact, the pathogen. And the other is sexually transmitted disease, STD, which refers to the disease state that develops from that infection. Next slide, please. So in terms of population health, chlamydia and gonorrhea are the most common sexually transmitted diseases in Texas, and syphilis is actually on the rise. Dallas County has recorded more than 22,000 cases of chlamydia, over 10,000 cases of gonorrhea, and more than 300 cases of syphilis in 2022 alone. Everyone's at risk for STDs, but there are groups that at higher risk, and those groups are African Americans and Hispanic racial ethnic groups. 50% of chlamydia cases were diagnosed in those groups. The majority of those were female, 58% versus male, 42%. 52% of gonorrhea cases were diagnosed in those groups. The majority of those were male at 69% versus female at 31%. And 74% of syphilis cases were diagnosed in those groups, and the majority of those were male at 74% versus female at 26%. Dallas County is also seeing a rise in the new cases of HIV. New diagnosis of HIV has increased by 8% over the last 5 years. It's primarily diagnosed in African American men ages 25 through 34. The prevalence of HIV has increased by 13% over the last 5 years, and right now there are roughly 6,300 people living with HIV in Dallas County. Next slide, please. Okay, so when you see your provider, they may assess your risk. One area they may assess is your behavioral risk, and that is to discuss sexual behaviors that can place people at higher risk for infections, such as unprotected sex, multiple sexual partners, anal sex, or drug and alcohol use before sex. They may also assess your biological risk, which would be testing for risk markers for STDs and HIV acquisition or transmission. Those factors may be molecular, genetic, any sort of immunological variations that may increase your susceptibility, and then also sex, age, and the overall health or presence of any genetic conditions people may have. Next slide, please. Also, when you see your provider, they may utilize the 5P approach to obtaining a sexual history. The first P is partners. They may ask you about your number of partners or the gender or genders of your partners. They may ask about your practices. That would be the next P in terms of sort of what sexual contact have you had or do you have, and the type of sexual intercourse you have. The next P is protection from STDs or STIs. They may ask if you and your partner have discussed getting tested or have been tested before, and currently what sorts of protection is being used. The next P is prior history of STIs. They again may ask if you or your partner have ever been tested for STIs or HIV, or if you or your partner's ever been diagnosed with an STI in the past. Some additional, more pointed questions may be if you've ever had any sort of history or your partner has of injected drug use that does place patients at higher risk for HIV and hepatitis. And then general questions about your sexual health that you may have, they may ask you about that as well. The last P is pregnancy intention or family planning in terms of do you have any plans for children in the future, and currently, you know, how important it is for you to prevent pregnancy until the time you're ready. And then may also just ask you if you have any general questions on how to prevent pregnancy. Next slide, please. So in terms of primary prevention methods, there's general prevention with condoms, topical microbicides or spermicides. Those can come in the forms of gels, creams, suppositories, lubricants, or anti-retroviral agents. Pre-exposure prophylaxis. There are studies on an antibiotic. It's called doxycycline. It's used for many different things, but it can be used for sexually transmitted diseases, and also antiretrovirals for HIV can be given for pre-exposure prophylaxis. Also for post-exposure prophylaxis for HIV and STIs. HIV medications can be taken for 3 days after exposure, and similarly doxycycline for other STDs. There are HIV seroadaptive strategies. Some patients will modify their sexual behaviors based on their HIV status. And there's also abstinence and reduction in quantity of sexual partners. There's also vaccinations available. The human papillomavirus or HPV, hepatitis A virus, hepatitis B virus are all sexually transmitted. The HPV vaccine is recommended in male and female adolescents up to the age of 26 years old. The hepatitis B vaccine is recommended for all unvaccinated or uninfected people who are sexually active with more than one partner or who are being evaluated or treated for an STD. And then the hepatitis A and B vaccines are recommended for men who have sex with men, persons who inject drugs, persons with chronic liver disease, and people with HIV or hepatitis C infections who have not had hepatitis A or B. Next slide, please. So lastly, the treatment of STDs, some are considered curable. Syphilis, gonorrhea, and chlamydia can all be treated with antibiotics. Some patients with hepatitis C can be considered cured with direct-acting antivirals. The ones that are not curable but manageable are the herpes virus. Antiviral medications are given for the herpes virus. The hepatitis B virus, antiviral medications are given for that as well, for management. Some patients with hepatitis C are on antivirals as well. For the human immunodeficiency virus, which I've been calling HIV, that's often known as, antiretroviral medications can be given. And for the human papillomavirus, HPV, topical medications can be used, and the removal of any skin lesions can be done through freezing, burning, or surgical or laser removal surgery. Next slide, please. So all in all, maintaining good male sexual health is essential for both you and for both your physical and emotional well-being. I want to thank everyone again for having me, and we'll turn things over now to Dr. Allen. Thanks again.
Thank you, Dr. Langmaid. Good afternoon, everybody. I am Tom Allen. I'm a medical director of behavioral health at Blue Cross and Blue Shield, and I'm joined today by Andrew Vitale, who's a counselor at Headway, which is a behavioral health treatment program. And we are going to talk about men's mental health. Next slide, please. So in terms of prevalence, 1 in 5 adults in the US experiences a mental illness every year, and this is both men and women. So about 20% of the population has a diagnosable mental illness. So it's pretty common. Although both men and women are affected by mental illness similarly, it's often overlooked in men. 6 million men are affected by depression in the US every year, and suicide is one of the highest causes of death among men. However, if we look at rates of diagnosed depression among men, it's diagnosed about half the time compared to women. And this doesn't mean that men are less depressed in general as women. It means that men's depression manifests differently as it does in women. So in men, it can be externalized sort of behaviors like aggression or anger. And in women, it can be more internalized, like sadness or guilt. And also, men are less likely to seek treatment for depression compared to women. Often men, and we'll get to this more later, see depression as a weakness, and this can lead to feelings of embarrassment and shame, and it can really interfere with their ability to seek help. So as a result, men are more likely to suffer in silence. Next slide, please. So if we look at some of the statistics of prevalence, looking at major depressive disorder on the right here in this bar graph, and substance disorder on the left. The orange bar is Dallas, Fort Worth area. The yellow is Texas in general, and the blue is United States. If we look at the right for major depression, the prevalence among adults in Dallas County is about 6%, which is about 1 out of every 15 individuals. And that's similar in Texas, a little bit less than what we see in the United States. And then on the left side, the prevalence of substance use disorders among adults in Dallas is about 8.2%, which is about 1 out of every 12 individuals, a little bit less than what we see in Texas and in the United States. But it's significant when we talk about men with substance use disorders. Some recent statistics have shown that the rates of substance use disorders among men is 3 times the rate among women. So men are more likely to have a substance use disorder than women. And if we look at heroin, for example, men have double the rate of heroin use compared to women, and death by overdose is 2 to 3 times more likely among men than it is among women. And this is for opioids. Next slide.
Yeah, we passed. Thank you.
So in terms of prevalence of suicide in Texas, we look at this bar graph. On the left here is suicides by firearm, and the light blue is Texas, the darker blue is the United States. We see that in Texas, it's close to about 9 individuals out of 100,000 dies of suicide by firearm. And it's more common than suicide by other means. How does this apply to men? Men die by suicide at a rate 4 times higher than women. So about 3 out of 4 suicides is completed by a man. We also know that Texas has one of the highest suicide rates of all the states in the US. It's higher than the national average. And men living in rural areas of Texas and rural areas in general have a 33% higher risk of suicide than those in urban areas. And this could be due to isolation or increased economic hardship, for example. As we know, men, when they're depressed, they don't like to reach out for help, often internalize and suffer in silence. And then if we add on to this that men often express depression through hostility, anger, violence, increased impulsivity, increased substance use. If we combine all of that with the presence of a firearm, it really increases one's risk for completing a suicide. So you have an individual who's using substances, impulsive, access to a firearm, depressed, suicidal, they're more likely to actually carry that out. Next slide. And in terms of leading risk factors for men, the biggest ones is masculine stereotypes. We all know in society that there are certain constructed beliefs about what it means to be a man. Typically things like, you're not supposed to show emotions, you're supposed to be stoic, you're not supposed to ask for help. All of these stereotypes are untrue because we all have emotions, we all need help. But it can really interfere with men's comfort in talking about feelings or reaching out to help, so that those masculine stereotypes can really get in the way at times of men getting help. And then traditional gender roles, for example, men often see themselves as primarily financially responsible for their families. So, for example, if they lose their job and they feel that the security of their family is at risk, they're at really high risk for depression and suicide. There's a great deal of shame around that. And in fact, unemployed men are more than twice as likely to kill themselves as employed men or unemployed women. So it's a particular phenomenon that's higher risk among men. Shame, we've talked about, if kind of how they see themselves doesn't match up to that external definition of that kind of masculine stereotype. Suppression of emotions, acting out behaviors. Anger is one of those behaviors, and for men, it's one of the more acceptable emotions to express at times. Often men use anger to cover up or mask other emotions that are deeper, that are unacceptable, like depression or anxiety. And in fact, anger attacks and aggression among men are 3 times more likely to occur than among women. And men who rigidly adhere to these social definitions of masculinity are also tend to commit higher levels of intimate partner and sexual violence toward women. So definitely a higher risk for men who are depressed. And then also, as we know, substance use disorders, it increases impulsivity, but also it's associated with higher risks of death due to suicide, but also overdose. Next slide, please. And then finally, looking at groups that are high risk, we touched on this before, but those who have financial challenges, whether it's bankruptcy or foreclosure, that puts men at increased risk for suicide and depression. In fact, 1/4 of suicides among men are attributed to the rising rates of unemployment. And this is especially the case in rural and remote areas where there's been a decline in traditional industries. Health status, particularly chronic health conditions like heart disease, physical disabilities can increase one's risk. Minority groups are at higher risk. For example, Black adults are more likely to experience emotional distress compared to white adults. And this is primarily due to historical trauma, discrimination, and only 1 in 3 Black adults with a mental illness actually seeks help. And this is primarily due to under-identification of mental health issues in certain communities of color because of unconscious bias among providers, under-reporting of mental health issues by individuals because of stigma, lack of access to providers due to social inequalities, and also lack of trust in the healthcare profession because of historical racism. We look at identity as a high-risk group. Men who identify as gay, bisexual, transgender are also at high risks compared to those who are not, largely due to lack of social acceptance of who they are and the resulting distress that they feel. Divorce is a high risk. Often for men, when they have a divorce, they frequently lose custody of their children. And for men, families and their coworkers often are their only sources of support. So if you lose a job, you lose a family from divorce, that really spikes feelings of isolation, feeling alone, and that's a huge risk factor for depression and suicidality. Veterans are also at higher risk for depression. In fact, the rate is about 2 to 5 times higher than those who are not veterans. And also rates of suicide among veterans are about 1.5 times compared to the general population. A lot of this could be due to PTSD or challenges adjusting to civilian life, but also veterans report pretty low rates of social support. About 29% of veterans reported adequate social supports, and this can lead to social isolation and increased depression. And then finally, high-risk jobs, first responders, people on the front lines, they experience trauma on a day-to-day basis that can develop PTSD and certainly increase risk for depression and suicide. And before I hand this over to Andrew, I just wanted to kind of give you sort of a thumbnail guide on how to talk to men about mental illness, how to assess how they're doing, how to help them get into treatment. So kind of one good approach is to just, check in with those you're close to, ask them how they're feeling, non-judgmentally, just be curious. Often men may not want to answer or put you off, but ask again at a later time. Look for changes in behaviors, especially the ones we talked about. Offer support, listen, be patient. Definitely reaffirm that depression is not a weakness. We all go through periods like that in our lives. Seeking help is not a weakness. If you're concerned that they're suicidal, ask them directly. And and on a previous slide, there was the number for 988, which is the crisis and suicide prevention hotline. If you or someone you love is at risk for suicide, or you're worried about imminent danger, call that number, talk to a professional, really get help right away. And then finally, if you think they need help, or if you yourself think you need help, call your doctor, whether that's a primary care doctor or a mental health professional, and get some more attention. So that's it. I will hand this over to Andrew, who will talk more about mental health conditions and some treatment options.
Thank you, Dr. Allen. Hi, everyone. I'm Andrew. I'm a counselor at Headway, which I'll tell you a little bit about if you've never heard of it. And I'm also going to talk to you about the different ways that mental health struggles can present themselves. Those different struggles are depression, anxiety and stress, injuries and accidents, substance abuse and addictive behaviors, and suicide. Now, we've all experienced some level of depression at some point in our life. You might have woke up one day and it's a little bit harder to get out of bed than usual. There's not a ton of motivation, to do the things you usually do. The things that usually bring joy might feel like a struggle or like they're not appealing. You can feel irritable, empty, even worthless, right? And what's also common in depression is a change in sleep patterns, feelings of fatigue, changes in appetite or weight. And one that's very unique, which isn't often thought of with depression, there can be sometimes unexplained physical problems, maybe a headache or a stomach ache that, docs give you a clean bill of health and there's no other reason for it. The next mental health struggle is anxiety and stress. And like depression, I think we've all experienced anxiety and stress at some point in our life. These are pretty pervasive feelings. May have been a time when you couldn't stop worrying about something, right? You wanted to change the thing you were thinking about, but you just couldn't. You feel tight in your body and tense. Maybe you feel like, truck is on your chest. You feel tight in your chest. You're not sure why. You can even feel lightheaded, right? Sweat. Those are symptoms of anxiety and stress. Now, these aren't great things to feel, and we want them to go away, right? So when we do experience these things, we can sometimes think of ways to self-soothe or self-medicate. And some of those ways to self-soothe can be substances, alcohol, drugs, addictive behaviors, right? Eating too much to cope, shopping too much to cope, gambling. Combine these three things, right? If you're not seeking help, you're feeling depressed, you're feeling anxious, you're using drugs and alcohol to self-medicate, opens the door for injuries and accidents. You're at work, you're distracted, you hurt yourself, right? As an example. Then to go back to Dr. Allen's point, for a lot of men, you take pride in providing for your family, and suddenly you can't do that. Now you're really in the hole, so to speak. And then in the most tragic cases, most devastating cases, result of mental health struggles can be suicide. A way to get ahead of these things, right? Or of course, address them as they're happening is to get help. It's right there. Headway is one of the ways to get that help. And one of the things that I want you to take with you is that you don't need to be in crisis to do therapy. It can be very helpful at any point. And honestly, I speak from experience as well, just feels good. Feels good to get things off your chest. Feels good to hear things said back to you objectively. It's just good for you. Historically, getting mental health care seeing a therapist, it was a little difficult, a little obscure, how much it would cost or how to do it, right? Now you can simply go on to Headway, headway.co, CO. It's even a little barcode here that you can scan. You'll see tons of providers that you can choose from. Read their bios, pick one that you like. It's easy to get a good fit. And then you can see these therapists in person, which is more traditional, or you can even do it from your laptop. If you want to stay in your bedroom, you're a busy person, and you'd like to do therapy from home, you can do it virtually. And one last point is therapists can also help connect you to other providers. If you're struggling with some other things that the other doctors on this call today talked about, a therapist can help connect you to a provider that can help treat that disorder or that illness. So that's it for me, and thank you very much, City of Dallas, for your time.
Thank you, Andrew, and thank you to all of our fantastic presenters that were on today. And also, again, Reginald, we appreciate you and we thank you. Would you like to go ahead and close us out today?
I surely would. I want to first of all thank everyone. I want to thank Laura Wolf from Blue Cross Blue Shield for putting this together. She's been absolutely amazing to work with. City of Dallas folks. She is our representative from Blue Cross Blue Shield on our particular medical account, guys. So keep that in mind as we continue. I'm going to also thank Dr. Lesko, Dr. Allen, Laura, help me out just a little bit with the other doctor, Dr. William.
Dr. Langmaid.
Langmaid. Dr. Langmaid, thank you so much for your part on sexual health, for just jumping in here at the last moment with that. And again, to Andrew Vitale and to all of our distinguished guests that were a part of this forum today. I think if a lot of this information are things that we don't think about, some of those demographics as related to City of Dallas, persons in the City of Dallas and in the County of Dallas, I think that was all of that was very, very instrumental information for us. So I want to thank all of our distinguished guests for that and look forward to working with you guys in the near future. Thank you to all of the men at City of Dallas. Give yourselves a hand. Thank you to all of the men who joined today. And thank you to all of the women who are on the call as well, gaining this information for their spouses and partners and all of those that have been a part of this whole effort. We really, really, really appreciate it. I hope you guys took something away that will encourage you to make sure that you're getting your physicals. As you guys know, we have a wellness incentive. I don't want to talk too much about that, but on this particular call, but I do want you guys to take advantage of the wellness incentive if you have not already, and do the necessary steps that you're seeing announcements about. Those announcements are coming out over and over again up until the last day, which is August 31st. So be mindful of that. Get that physical in, get those necessary health assessments in. And go to your physician for any of these of your health needs or your mental health needs, and just take care of this kind of thing. This is very important to me. I have people in my life who have passed away. I had a cousin who was around my age, and he died at 49. Had not had a physical since he was in high school and played football. So he literally, his wife made him go to get a physical. Again, that help from women. Wife made him go get a physical, called him back very quickly and told him like a couple of days later that he did have colon cancer. And within about 6 or 7 months, my cousin was gone. So this is very, very important to me. The men's health and men's mental health is very, very important to me, and I hope as important to you. I also want to say to everyone that participated here today that if you want to follow up with Headway, let me know this, Andrew, before you actually get off of here. The Headway I know that you explained that Headway is actually free. It's a free service for therapy services for persons who have, is it for persons who have the medical plan? Do you have to have the medical plan for that, or is it something that is available to anyone that is an employee?
So there are free resources that you can call, like suicide hotline and things like that.
Absolutely.
Headway is a free service where you can look for therapists, but typically, you'll pay those therapists a copay. If you have insurance.
Okay. Thank you for clarifying that. I appreciate that. Okay, so thank you so much. So this is how you actually find a particular therapist. That makes a difference, guys. Okay, and if you would, Andrew, could you in the chat, could you put those resource contact informations in the chat so that we can have that available to us for Headway at some point? And it'll be, even after the call, they can still go back and access that as well. All right. I see that Bracy Goodwin has a question. You have a question or a comment, sir?
Yes, thank you, Reginald. Bracy Goodwin with Office of Risk Management, City of Dallas. Thank you so much. I just wanted to know if this PowerPoint presentation was available, that we can download it all. I'm also a chaplain, and my local church too, we have what we call locker room discussion with the men, and I would love to go ahead and present some of this information.
Okay, awesome. Let me add, Laura, if you would, could you clarify that for us at this point?
Certainly. Unfortunately, due to varying reasons, we are not allowed to share this slide deck, and I apologize for that. But if you want to, Reginald, if you want to maybe there's somehow we can talk together offline with Bracy and see of any possible options.
Okay, certainly. Certainly, Bracy, we will, I'll definitely reach to you, and I'll reach to Laura, and we'll try to get you as much of the information that was included with this. I did not know for sure if there were copyright infringements or something like that. So Laura did explain that, but we will definitely reach to you specifically because of your ask. We will definitely reach to you about getting some of that information over to you.
All right, thank you, Reginald. Appreciate it.
You're welcome, sir.
I will drop the resources that they had that the doctors provided. I'll put that in the chat also. The resource page.
Got it, Laura. Yep, got it. Thank you, Laura.
You're welcome. Thank you.
Okay, ladies and gentlemen, again, thank you. Are there any other questions? I wanted to ask one question of Dr. Lesko, if I can, really briefly. I wanted to ask Dr. Lesko, what is your thoughts, or what are some of your thoughts about temporary or prolonged use of weight loss, those diabetic weight loss meds, your Mounjaro, your Wegovy, some of those others that are out there? What is your thought about that? Do you think that's a good option for men who do have excess weight around the waist and that sort of thing to drop weight?
Hey, Reginald. So, different health plans have different specific requirements around these types of drugs for that indication. And I do know for a fact that many carriers don't actually cover it for that specific indication. Now, there are other reasons that it could potentially be used that that are not necessarily related to obesity. or being overweight. So I think ultimately the bottom line is that there really isn't a whole lot of good, strong medical evidence to demonstrate the long-term efficacy as well as the risks associated with those particular medications when used on a long-term basis. So there's, and I believe that that's one of the reasons that many of the major carriers don't cover it specifically for that indication.
Okay.
At least currently. And obviously, as additional research is done, clinical research, and there's a stronger body of scientific evidence, it's possible that those policies could change over time.
Okay. All righty. All right. Thanks so much for that.
Dr. Lesko, we have a question. We have a question in the chat. How often should men have a colonoscopy done?
So that varies depending on each individual, their situation, their level of risk, and if they've had any previous colonoscopies and what the findings on those colonoscopies are. So from the standpoint of an average risk person, meaning somebody that doesn't have any predisposition to colon cancer, after having a colonoscopy, and if that colonoscopy is normal, the recommendation is 10 years after that.
Okay. I didn't
Just
know
as
that.
Bracy had described in his response to the chat, he had one every 10 years.
Okay.
And
awesome.
that goes up to the age of 75. Between the ages of 75 and 85, it's more of a conversation between you and your doctor at that point.
We have one more question, and I believe this is probably for Dr. Lesko. Is there another alternative to BMI for people who tend to be on the more muscular side?
Yeah, that is the one limitation, the one glaring limitation of BMI are folks that are muscular, lift a lot of weights, but are otherwise healthy. And that's where waist measurement is probably a more relevant measurement to be able to determine risk.
So the actual waist measurement as opposed to just relying on the BMI measurement.
Correct.
Okay, awesome. Okay.
And you said that was 40 for men, correct, Dr. Lesko?
40 for men is sort of the number in which it's been determined that there's a correlation between that measurement and cardiac risk.
Oh, okay.
Ladies and gentlemen, if there are additional questions at this point, we are out of time, and I don't want to hold any of our distinguished guests or you, our distinguished other guests from City of Dallas any longer. So if you have additional questions that you would like answered by some of our distinguished colleagues, feel free to email me at reginald.jackson2, and I will try to get those answers for you at dallas.gov, reginald.jackson2 at dallas.gov, and I'll try to get those answered for you as quickly as I possibly can. I appreciate you again. Y'all have a great rest of the day. And again, thank you to everyone that joined us today. Have a good day.
Thank you.
Bye-bye.
Helpful. I really appreciate her assistance. I would like to say to Eva, great job. Sincerely, Charlotte H.